Your doctor has recommended you undergo a transurethral resection of the prostate, or TURP. But what does that actually mean? The prostate gland is a walnut-sized organ which is part of your reproductive system. It provides some of the fluids contained in semen. The prostate is located just under the bladder and behind the testicles. The urethra, the hollow tube that carries both urine and semen to the penis, passes through the prostate. In some men, the prostate gland becomes enlarged. Symptoms of an enlarged prostate include a full bladder feeling even when the bladder is empty, pain when urinating, weak urinary stream, infertility, and sexual dysfunction. To relieve you and your symptoms, your doctor feels that you would benefit from a surgical procedure called TURP. TURP is designed to relieve symptoms by reducing the size of the prostate. It is also a diagnostic procedure. Tissue removed during a resection of the prostate, or TURP, is routinely screened for the presence of cancer. TURP is considered to be a simple surgical procedure. However, there are some alternatives. Some patients benefit from lifestyle changes. Your doctor may ask you to try several adjustments, including trying to spend less time sitting, taking warm baths, and increasing sexual activity. In a small percentage of cases, the prostate becomes enlarged due to a bacterial infection. Antibiotics can often treat the problem. But the majority of cases are not bacterial and will not respond to antibiotics. If you decide not to have the surgery your doctor recommends, you may experience symptoms that become more severe. And if the cause of your disease is in fact cancer, you may be placing your life at risk by declining your doctor's recommended treatment.
On the day of your operation,
You will be asked to put on a surgical gown. You may receive a sedative by mouth, and an intravenous line may be put in. You will then be transferred to the operating table. Once on the table, your feet and legs will be placed in an elevated position with your knees apart. And the nurse will swab the penis with an antiseptic solution. Your doctor will then lift your penis upward. A well-lubricated instrument called a resectoscope is then gently inserted into the urethra. When the resectoscope reaches the back of the penis, your doctor will pull the penis downward in order to create a straight path into the prostate. Once the instrument is inside the prostate, your doctor will extend a small loop of sharp-edged wire from the end of the resectoscope. Using this tool, your doctor will then scrape excess tissue from the prostate, restoring it to its normal size. Tissue removed from the prostate may be sent to a laboratory for analysis. When the surgery is complete, your doctor will remove the resectoscope. Your doctor will probably ask you to wear a temporary Foley catheter. A Foley catheter is a narrow tube inserted through your urethra and into your bladder. The catheter is connected to a bag that is attached to your leg by a strap. While the Foley catheter is in place, urine will pass from your bladder into the bag. You will not need to urinate into a toilet. The nurse will show you how to change the bag when it's full. An appointment will be made for you to return to the doctor's office in a couple of days to have the catheter removed. As soon as the anesthesia wears off and you feel comfortable, you will be allowed to leave.
Most patients experience at least some pain following surgery, but if properly handled, it shouldn't present any serious problems. Pain used to be regarded as an unavoidable side effect of surgery, but today, pain can be managed with great effectiveness. And as the patient, you have an important role to play. Before surgery, be sure to ask the medical staff about the type and duration of pain normally associated with your surgery. Find out in advance about your pain management options. Work with the staff to develop a pain management plan. Discuss your options. There are alternatives to drugs that can lessen your need for pain medication. Ask your doctor for help in finding a pain management class. Many of these workshops teach helpful relaxation techniques, positive thinking, and nerve stimulation exercises. Following surgery, make sure to let your nurse know right away how you're feeling and whether or not you are in any pain. Be specific and help them to measure your discomfort. If you're having trouble expressing yourself, try to rank what you're feeling on a scale from 1 to 10. Never be shy about asking for help. If you experience pain that just won't go away, report it to the nurse. Pain is an important indicator that helps you and your medical staff understand your body's healing process.
TURP only rarely leads to complications. Unlikely but possible complications include excessive bleeding, damage to the urethra, slow return of urinary control, inability to control urine and to attain an erection, infection of the urinary tract, injury to the penis. At home, you should be able to resume normal activity as you feel able.
Germs are present always on your hands, and they can be transferred to other parts of your own body, to the family member for whom you're caring, your patient, and to any clean object you touch. By washing your hands correctly, you remove germs from your hands. Hand washing is the single most important way you can prevent infection from occurring and prevent the spread of infection. You must carefully wash and dry your hands before and after each time you care for your family member, your patient. Before and after you handle your patient and your own food and drink. Before and after you manipulate any contact lenses. Before you apply and after you remove gloves. After you use the toilet. After you cough, sneeze, or blow your nose. After contact with anything that could be soiled or have germs on it. After you pick up any object from the floor. Hand washing takes a minimum of 10 to 15 seconds, longer if your hands are soiled. The longer you wash, the more germs are removed. The friction generated by rubbing your hands together removes the germs from your skin, and running water can then wash them away. Every time you wash your hands, take your time and don't rush. Do the hand washing carefully and thoroughly. Use liquid soap from a dispenser. Bar soap holds germs on its surface. Make sure you have paper towels and a waste receptacle nearby. Remove all jewelry from your hand except a wedding band, and push your watch and sleeves up away from your hands. Turn on warm water. Point your fingers down to prevent water running onto your arms and wet your hands. Apply soap from the dispenser. Point your fingers down and rub your hands vigorously together in a circular motion. Start counting seconds at this point. Intertwine your fingers to clean all surfaces of the fingers. Rub your fingernails against the palm of the other hand to get soap under the tips of the nails. If your nails are soiled, clean under them with an orange stick or brush. Keep your hands down and continue to rub them together in a circular motion until the end of your count for 15 seconds. Keep your hands down and rinse them from the wrist to fingertips. Pick up a clean paper towel and turn off the water, still keeping your hands pointed down. Discard the paper towel into the waste receptacle. Pick up another clean paper towel and carefully and completely dry your hands. Discard the paper towel into a waste receptacle. The key points to remember are that friction is critical for removing germs, and the friction should be applied for at least 15 seconds. Always keep your fingers pointed down and turn off the water with a paper towel. Your correct use of disposable non-sterile gloves helps prevent the spread of infection and protects both you, the caregiver, and the person receiving care, your patient. The gloves used most often are made of latex, are powder-free, and are easy to put on and take off. They are used once only and then discarded. Gloves are not worn all the time in giving care. Touching your patient with bare hands shows love and respect, sends a message of caring and acceptance, and provides comfort. Gloves should always be worn if contact is likely to occur with blood, body fluids, excretions such as urine or feces, mucous membranes such as in the mouth or genitalia, or non-intact skin. Before you put gloves on, carefully wash and dry your hands. Pull a glove out of the box with one hand and slide it onto your other hand. With your gloved hand, pull another glove out of the box and slide it onto your bare hand. Interlace your fingers to make the gloves fit more smoothly and comfortably. You should remove your gloves immediately when the patient care procedure is complete, if the gloves are heavily soiled, if a glove is torn, after you have touched your patient's secretions or excretions, before touching another part of the body, before touching any clean surface or object. When you remove your gloves, your intent is to avoid touching the contaminated surfaces of the gloves with your bare hands. To take off your gloves, firmly grip one glove at the base of the palm and pull it off inside out. Keep holding it in the palm of your gloved hand. Slip your bare fingers under the wrist of the remaining glove without touching its surface. Push the glove down and off with the first glove tucked inside of it. One glove is now inside the other and both are inside out. Drop the bundle of gloves into a sealable plastic storage bag and seal it tightly. Drop the sealed bag into the trash. Carefully wash and dry your hands. A closed urinary drainage system consists of a catheter inserted into the urinary bladder and connected via tubing to a drainage bag. The catheter is retained in the bladder by an inflated balloon. The drainage of urine is totally dependent on gravity. Therefore, tubing and the drainage bag to collect urine must always be below the level of the bladder. As a caregiver, your responsibilities to a patient with a closed urinary drainage system are to ensure that the patient drinks at least 8 ounces of fluid daily, preferably water and juice. To ensure that the catheter and tubes are in a good position and open to allow urine to flow freely into the drainage bag, and to keep the body opening where the catheter enters the patient clean and free from secretions. Ensure that the catheter and drainage tube are connected and that there is sufficient slack in the tube between the body and the thigh to allow the patient to move the thigh without pulling on the catheter. The drainage tube should be attached to the patient's leg by a tie or clip. The drainage bag can be attached to the bed frame, should never touch the floor, and should always be kept below the level of the patient's bladder. The drainage bag should be emptied at least daily, more often if it fills, in order to prevent infection in the system, reduce odors, and keep the system open and flowing. To empty the drainage bag, the following steps should always be followed. Carefully wash and then dry your hands with a paper towel. On a tray covered with clean paper towels, assemble the following equipment: a large plastic or glass container, a large plastic sealable storage bag, disposable gloves, alcohol wipes, paper towels, and place the tray on a stable surface adjacent to the bed. Carefully wash your hands. Dry them with a paper towel. Discard the paper towel into a wastebasket. Put on your disposable gloves. If you are cleaning your own catheter, gloves are not essential. Place the container under the drainage bag. Remove the drain from its holder. Point it into the container and release the clamp on the drain to allow the urine to flow into the container. Do not allow the drain to touch the container or anything else. When the drainage bag is empty, close the drain, wipe the end of the drain with an alcohol wipe, and replace the drain in its holder at the base of the drainage bag. Discard the alcohol wipe into the plastic storage bag. Check that the catheter and tubes are in place. Take the equipment tray and the container of urine into the bathroom. If your doctor or nurse has asked you to record the amount of urine, measure and make a note of it now. Discard the urine down the toilet and clean the container with liquid soap and water. Remove the gloves and discard them into the plastic storage bag. Seal the bag and put it into the trash. Wash and dry your hands. Discard the paper towel into the trash. Once each day, or according to your doctor's instructions, you will need to clean the urethral meatus, the opening where the catheter enters the body. The drainage bag should be emptied every 6 to 8 hours, more often if it fills, in order to prevent infection in the system, reduce odors, and keep the system open and flowing. To empty the drainage bag, the following steps should always be followed. Carefully wash and then dry your hands with a paper towel. Discard the towel into a plastic-lined wastebasket. On a tray covered with clean paper towels, assemble the following equipment: a large plastic or glass container, a large plastic sealable storage bag, disposable gloves, paper towels. Place the tray on a stable surface adjacent to the bed. Carefully wash your hands, dry them with a paper towel. Discard the paper towel into the wastebasket. Put on the disposable gloves. If you are emptying your own bag, there is no need to use gloves. Place the container under the drainage bag. Remove the drain from its holder. Point it into the container and release the clamp on the drain to allow the urine to flow into the container. Do not allow the drain to touch the container or anything else. When the drainage bag is empty, close the drain. Replace the drain and its holder at the base of the drainage bag. Check that the catheter and tubes are in place. Take the equipment tray and the container of urine into the bathroom. If your doctor or nurse has asked you to record the amount of urine, measure and make a note of it now. Discard the urine down the toilet and clean the container with liquid soap and water. Dry it thoroughly with a paper towel and discard the paper towel into the trash. Remove your gloves and discard them into the plastic storage bag. Seal the bag and put it into the trash. Wash and dry your hands. Discard the paper towel into the trash. Some patients are able to wear a leg bag during the day to allow them to walk about. The larger drainage bag is disconnected from the catheter in order to attach the leg bag. The leg bag is secured to the front of the thigh or lower leg. After it's been disconnected from the catheter, the larger drainage bag can be unhooked from the bed frame, carried into the bathroom, and emptied directly into a measuring device or the toilet. The procedure to replace a bedside drainage with a leg bag to enable the patient to move about is as follows. The equipment you will need to assemble includes the leg bag, alcohol wipes, a cap for the drainage tube, paper towels, disposable gloves, and a sealable plastic bag. Take the equipment on the tray to the bedside. Wash and dry your hands.
If you are doing this procedure for another person, put on disposable gloves.
Place a paper towel under the connection of the catheter to the drainage tube. Disconnect the catheter from the drainage tubing. Wipe the end of the drainage tubing with an alcohol wipe and discard it into the plastic bag. Cap the end of the drainage tube and place it carefully on the bed so that it does not fall on the floor. Remove the cap from the end of the leg bag connector. Connect the leg bag to the catheter.
Strap the bag to the outside or front of the thigh or lower leg so that there is no tension on the catheter connection.
Check that the label TOP on the leg bag is at the top. Discard the paper towel into the plastic bag. Reverse the procedure when the patient returns to bed. Take this opportunity to empty the bedside drainage bag into the toilet and wash and rinse the bag before returning it to the bedside. Remove your gloves, discard them into the plastic bag, seal the bag and discard it into the trash. Wash and carefully dry your hands.
The leg bag will need to be emptied every 2 to 3 hours. Following surgery, you may have a suprapubic catheter or be on a program of intermittent self-catheterization as your bladder recovers from the effects of surgery. To help your bladder heal, you will need to increase the time between self-catheterization or unplugging the suprapubic catheter until there is no need for a catheter. To know the time intervals needed between catheterization or removing the plug, you need to keep a record of the amount of urine you are producing when you void and when you catheterize or unplug. You should try to void every 2 to 3 hours and immediately before you self-catheterize or remove the plug. Void into the hat placed into the toilet and measure the amount of urine in the hat. This amount is called the voided volume. Write this amount on your record sheet every time you void. When you self-catheterize or unplug, measure the urine that empties from the catheter. This amount is called the post-void residual, or PVR, and is written down on your output record sheet in the PVR column. Look at your output record sheet. Each entry on the record will have a date, time, and the amount of urine in either the voided volume column or the post-void column. Your output record can be taped to the back of the bathroom door to keep it handy. The basic guidelines for the timing of self-catheterization or plug removal during bladder retraining are: throughout the day, void as often as you like, at least every 2 hours. Measure each void in the hat. Write the amount in the voided volume column of your output record. Begin by self-catheterizing or unplugging the suprapubic catheter every 4 hours. Immediately before catheterizing or unplugging, void into the hat, measure the volume and write it in the voided volume (VV) column of your output record. When you self-catheterize or remove the plug, save and measure the urine that comes out of the catheter and write the amount in the post-void residual (PVR) column of your output record.
If your post-void residual urine, PVR, is less than 150 cc's, you can increase your time intervals between catheterizations or plug removal by 2 hours, say from 4 to 6 or 6 to 8 hours. If your post-void residual urine, PVR, is between 150 and 250 cc's, you should keep the time interval between catheterizations or plug removal the same. If your post-void residual urine, PVR, is more than 250 cc's, you should decrease the time interval by 2 hours. Try not to self-catheterize or remove the suprapubic catheter plug more often than every 4 hours, unless you feel uncomfortable or full. Start in the morning from where you left off the previous day. You do not need to start over each day. Keep your output record to show your healthcare providers. Once you are consistently at 12-hour intervals between catheterizations or plug removal, consult your healthcare provider, who may tell you to stop the retraining process. The retraining process may take several weeks or even months. Do not get discouraged. Let's look at an example of a recording. In the morning, you wake at 8 a.m. and you could not void any urine. Point 0 is recorded in the voided volume VV column. Then you catheterize and produce 300 cc's of urine. This is recorded in the post-void residual PVR column. From the basic guidelines, you know you must wait 4 hours until the next catheterization or plug removal, unless you are uncomfortable. You will attempt to void every 2 hours and record the amount you void in the voided volume VV column. At 12 noon, you void 100 cc's and record this in the voided volume VV column. The 4-hourly catheterization or plug removal produces 150 cc's of urine, and this is recorded in the post-void residual PVR column. From the basic guidelines, this means you continue with 4-hourly catheterizations or plug removal. At 2 p.m., you voided 90 cc's and recorded this in the VV column. At 4 p.m., you voided 150 cc's and again recorded it in the VV column. You catheterize or remove the plug and produce 100 cc's of urine, which is recorded in the PVR column. Basic guidelines tell you that the next catheterization or plug removal can be moved out to 6 hours because your PVR was below 150 cc's. During the evening, you voided at 6 p.m. and 8 p.m. and recorded these amounts in the VV column. At 10 p.m., your voided volume is 175 cc's and your PVR on catheterization or plug removal is 125 cc's. Because your PVR is again below 150 cc's, you can increase the time between catheterization or plug removal from 6 to 8 hours. When you are self-catheterizing or removing the plug every 12 hours, you must set your alarm at night so that you will wake and attempt to void every 3 to 4 hours. Record each void in the VV column of your output record. The following problems or symptoms are reasons to contact your healthcare provider immediately. Little or no urine flow, cloudy or foul-smelling urine, sand-like material in the urine, bloody urine, a red or swollen urinary opening, difficulty inserting the catheter, pain in the lower back or lower abdomen, chills or temperature above 100.5 degrees.